Good morning to all. Today's class is the hematinics. These are the key micronutrients that are required both for the formation as well as normal functioning of hemoglobin as well as RBC. And these major micronutrients provided by the diet, these are iron, vitamin B12 and folic acid. And deficiency of either of this micronutrient leads to the anemia. Now comes on the iron. Iron deficiency is the most common cause of the nutritional anemia, and this is due to the inadequate iron intake, metabolism, blood loss, and increased requirement during the pregnancy. And iron is not only present in the RBC, it may be present, must present in the myoglobin, different enzymes like the cytochromes, catalase, peroxidase, and xanthine oxidase, and other mitochondrial enzymes. Iron is not only responsible for the formation of the and functioning of the RBC and hemoglobin. It also plays an important role in the immune functioning, cognitive development, temperature regulations, and normal functioning. And work with the other enzyme to synthesis of the collagen, several neurotransmitters. You see the dopamine, epinephrine, norepinephrine, and eicosanoids. And these are the pictorial demonstration. That's the requirement of the iron during the pregnancy, in the infant, child, and normal functioning and old age. These are the table showing the distribution of iron in the body of a healthy 70 kg persons. Hemoglobin, that is the protein present in the erythrocytes, is the major site of the containing iron, that is the near about 2600 mg. Another major things is the myoglobin, that is contained near about 400 mg, and this is the liver, that is stored in the form of the ferritin, and bone marrow near about 300 milligram. Hemoglobin is a protoporphyrin, is molecules having 4 iron containing heme residue, and to rise the hemoglobin level near about 1 gram per deciliter, it is required near about 200 mg of the irons. And full saturation of the ferritin hold 30% of the iron by weight. Iron is the ferritin is the basic moiety that store the irons, and other is the reticuloendothelial cells, that is the liver, spleen, and bone marrow. Hemoglobin contain 4 atoms of the iron per molecules and 1.1 mg of the iron per millions of the packed volume of the RBC is available. Ferritin basically is the reservoir that present on the GIT mucosa, store the iron, and when the plasma concentration iron is very poor, the production of the ferritin get diminished. Otherwise, when the plasma concentration of this iron is sufficient, and this ferritin make act as a reservoir for the iron in the GIT mucosa. Other is the apoferritin, that is the high molecular weight near about 450,000 and containing 24 polypeptide subunit, act as a core moiety for the reservoir of the iron. Now comes on the excretion. 2/3 of the iron is excreted from the GIT tract, as a extravasated red cells, iron in the bile, and the exfoliated muscle cells, mucus cells. And one third of the iron is secreted by the desiccated skins and the urine. And additional iron get lost during the maturation in the ovens. Other cause of the loss of the iron is the blood during the blood donation, and the chronic use of the anti-inflammatory drugs may causes bleeding the gastric mucosa and GIT disease. You see, the source of the iron, major source is the liver, dry foods, and germ yeast. There is some problem in the slide. These are the poor source of the iron. Okay, and these are the basic, these are the requirement of the daily intake of the iron. In infant it is microgram per kg, near about 67. In child it is 22, and adolescent male it is the 21. It is something is greater in female, and adult male is near about 30. In adult female is near about 21 and 21 is the things. And the mild to in the pregnancy its requirement get increased near about 80 mg microgram per kg of the body weight. And these are the different fragments where the iron demand get increases during the pregnancy. That is the external iron loss during the pregnancy, expansion of the red blood cells, fetal iron, and the iron in placental and the cord, and blast during the delivery. These are clinical use of the iron to treat the iron deficiency anemia, which can be caused by the chronic blood loss during the menorrhagia, hookworm, colon cancer. Increased demand during the pregnancy. When the supply is poor, demand is greater, it may lead to the anemia. Early infancy, inadequate diet intake, and inadequate absorption during disease or the GI surgery. Iron deficiency in the children may lead to the other metal toxicity, especially heavy metal toxicity, lead toxicity, because during the iron deficiency in the children it leads to the increased absorption of the other heavy metals. And premature low birth weight infant are the greatest risk for the development of the iron deficiency, especially if they are not breastfed or do not receive the iron fortified formula. Adolescent girl are the greatest risks. The dietary iron intake of the most of the girl of the age of the 11 to 18 years is insufficient to meet the requirement, and therefore iron supplement must be provided to that age of the particular girl, particular age 8 to 18. You can easily diagnose the iron deficiency of iron by symptoms, by nails, tongues, and these are the cells. Now comes on the different formulation. Oral iron, the preferred route of the iron administration is the oral, and in the oral ferrous salt are better absorbed than the ferric salt. And ferrous salt may be available in the hydrated form or dried salt. Hydrated form, the iron content is near about 20%, and dried without hydrated form with the iron content is something is greater near about 32%. And gastric irritations, constipation, sometimes diarrhea is the common adverse effect of the oral formulations. And in the table you see the average response to the oral iron. When the dose get increases, percentage of the absorption get decreases, and it is the total absorption of net absorption of the Iron get also increases when dose get increases of the iron and it is the percentage rise in the hemoglobin. These are the different formulation. Available formulation of the iron: ferrous gluconate, ferrous fumarate. Ferrous gluconate is near about contain 20% of the iron. Ferrous fumarate is the 33% of the iron. Colloidal ferric hydroxide 50% of the iron. Carbonyl iron, it is a very fine powder of particles are near about less than the 5 micron get easily absorbed. Other forms of the iron are formation are the ferrous succinate, iron choline citrate, iron calcium complex, ferric ammonium citrate, ferrous ammoniate, and so on and so forth. Now comes on the parental preparation. And why the need of the parental preparation? Parental preparation by injection is indicated only when the oral iron is not tolerated, maybe bowel upset, failure to absorb the oral iron during the inflammatory bowel disease, chronic inflammation that decreases the iron absorption, non-compliance to the oral absorption, and in the presence of the severe deficiency with the chronic bleeding, you must inject the iron by parental route, and along with the erythropoietin, because erythropoietin increases the erythropoiesis, and therefore oral iron is not sufficient to sufficient to the rate to the meet the demand of the this iron of during the erythropoiesis, and you must be injected by other give the iron by other route, a parental route. You see in this table here the iron requirement is calculated by 4.4 multiplied by body weight multiplied by the iron deficit. That is the common formula. Other iron preparation are the iron sorbitol citric acid. It is the low molecular weight complex. Absorption occurs directly into the circulation. No local binding in the muscle cell, but about 30% of the dose is excreted in urine, and therefore dose must be adjusted accordingly. It is contraindicated into the kidney disease, and dose is 75 mg intramuscularly daily. Or alternate day, ferrous sucrose. This is a newer formulation, a highly molecular weight complex of iron hydroxide with sucrose, that is the macromolecules, is taken up by the reticular endothelial cells. It is safer than the older formulations, and dose of the 100 mg can be injected IV, taken 5 minutes, once daily or once weekly, depend upon the conditions. The incidence of hypersensitivity reaction is very low. However, some guideline is available to must be checking the hypersensitivity reaction before the administration of this ferrous sucrose. Other thing is the ferric carboxy maltose, the newer formulation, latest formulation of the iron of the ferric hydroxide core stabilized by the carbohydrate cell is the macromolecules, and rapidly taken up by the reticular endothelial cells, primarily in the bone marrow up to the 80%, as well as other reticular endothelial cells, that are liver and spleens. And major side effect is the pain during the injection, rashes, anaphylaxis reaction is very rare, headache, nausea, abdominal pain, hypotension, flushing, and these are the major complication, not recommended for the children below the age of 14 years because the safety data is not available. Now comes on the intramuscular injection of the parental iron formulations. Injection is given deeply in the gluteal region using jet track technique. It is very important to avoid the staining of the skin. Iron dextran can be injected 2 ml daily or alternate day, or 5 ml each side on the same day. And these are the factor which increases the iron absorption by oral route, that is the gastric acid, low pH, heme form, that is the that heme form of the iron present in the meat and some non-vegetarian iron content, and high body demand. When the demand is very high, it get easily absorbed. When demand is low, it get sequestered into the GIT mucosa with the ferritin. And when the low body stores meat, protein factor, and vitamin C. These are the things which enhances the absorption of the iron. And these are the factors, conditions which decrease the iron absorption. They are the phytic acid present in the plants, oxalic acid, phytophenols. Then the body totally gets saturated, excess of the other metals, and antacid. These are the conditions where the iron, when iron is injected, it enter into the mucous membrane by the brush border, it get enter into the absorptive cell, that is cell membrane brush border, and make a complex this by this membrane binding protein, and this iron will enter into the make a complex with the apoferritin, that is act as a reservoir. And this, when this iron enter into the liver and even in the GIT mucosa, it get stored in by making a complex with ferritin, and this iron ferritin complex is the basic storage form of the iron. And once iron enter into the blood stream, this iron make a complex with transferrin. This ferrous form get reduced to ferric, and this ferric form make a complex with the transferrin, and this iron transferrin complex get enter into the cell by through the receptor, that the iron transferrin receptor, by the process of the endocytosis. And this iron transferrin complex, when get absorbed into the cell through the receptor, that is known as the iron transferrin receptor, by the process of the endocytosis, this iron is now available for the normal functioning of normal synthesis of the hemoglobin as well as RBC. By the acting of this lysosomal enzyme, this complex gets dissociated, iron get released, and transferrin get free, and this transferrin comes on the cell membrane to further make a complex with the iron, and this iron, when get excess, it get stored in the form of the hemosiderin to avoid the toxicity. Okay, interaction. Bioavailability of the iron ingested with the food is near about 1/2 to 1/3, and as compared to the fasting stage, antacid also reduces its absorption. So it is preferred to administer iron in the fasting stage. And sustained high rate of the red blood cell production require uninterrupted supply of the iron, and the oral dose should be spaced equally to maintain the continuous concentration, plasma concentration of the iron, to normal functioning as well as the production of the RBC. And the unwanted effect of the oral iron administration are dose related and induces the nausea, abdominal cramp, and diarrhea. And acute iron toxicity is the common toxicity in the children that gets have swallowed attractively colored tablet to mistake for the sweet, and after ingestion a large quantity of the iron get into the body may produces toxicity, and toxicity may be nausea, vomiting, diarrhea, abdominal cramp, so on and so forth. And if toxicity is very high, it may be leads to the serious complications. You may administer dexperoxamine, because dexperoxamine make a complex with the ferric ions, and you can manage the iron toxicity. Now comes on the vitamin B12s. These are the common source of the vitamin B12 for the vegetarian. These are the oats and milk. Other is the non-vegetarian source. Vitamin B12 and folic acid are also dietary essential micronutrient with along with the iron, and both are the necessary constituent that is must be available into the diet, and both are essential for the synthesis of the DNA, and as consequently for the cell division, and especially those body parts where the cell division is very faster in the bone marrow and GIT mucosa. At the early signs of the deficiency is the megaloblastic anemia, and pernicious anemia is the other form of the megaloblastic anemia due to chronic deficiency of the intrinsic fat that get released from the GIT. When you come on the history, it has been seen that it was 1925 where the a scientist who used the liver extract to cure the pernicious anemia and got the Nobel Prize in 1925, and later on in the Castle who find out that there are two things when one is the intrinsic factor that get released from the GIT mucosa, and extrinsic factor that is the vitamin B12 must be present on the diet. Both are responsible for the this type of the pernicious anemia. And after the 20 years it was Rees and co-workers and Smith and Baker who isolated this vitamin B12 and find out the X-ray structure of this vitamin B12, and also got the Nobel Prize. And it was the Michael and co-workers in 1941 who coined the term folic acid, folate. Earlier it was known as the vitamin M and the Wills factor that is present into the leafy vegetables, that is also responsible for the there is a problem into the slide. Vitamin B12. Vitamin B12 is a family of related compound containing cobalt atom. Here in hemoglobin there is iron, in the chlorophyll there is a magnesium, and basic ring is the protoporphyrin is the same. And the two dietary forms of the hemoglobin are available, that is the methylcobalamin and dextroadenosylcobalamin, and the synthetic form of the vitamin B12 is the cyanocobalamin. These are the principal source of the vitamin B12. Liver, calf liver, eggs. 100 gram of the calf liver contain 60 microgram of the vitamin B12. Eggs, 1 eggs of average size contain 1 microgram. Beef of 100 grams contain 2 microgram. Milk, 1 large glass contain 0.4. Hard cheese, 30 gram contain 0.6, and muscles. And this is the average requirement according to the age. In the children, neonate, it is below the children below the age of the 1 to 3 years, daily requirement is 0.9. 4 to 8 years, daily requirement is the 1.2 microgram per day, and so on and so forth. And at the age of 14 to 18, it is equal to the normal human, that is the 2.4 microgram per kg. And this vitamin B12 must be present in the diet. However, it's synthesized from the GIT microbial flora, but is not available for the human beings. These are the functions of the vitamin B12. Vitamin B12 is with the folic acid in the RBC maturation and cell proliferation, because it is playing a very important role in the DNA synthesis. In nervous system, it play very important role in the myelin synthesis, that is the covering of the neuron, and helping maintain of the antioxidant, and it is vital in the fat metabolism, protein metabolism, as well as folate metabolism. Use of the vitamin B12 to treat the pernicious anemia, in combination of the folate to treat the megaloblastic anemia, treatment of the psychiatric and nervous disorder, example dementia, memory loss, particularly into the aged people, help in the folate in prevention and therapy of the atherosclerosis associated with the high level of the homocysteine, because it reduce the level of homocysteine, it convert to homocysteine to methionine. And reduction of the peripheral nervous disorder like the neuropathic, diabetic neuropathic, trigeminal neuralgia, and so on and so forth. And this vitamin B12 in large dose in the IV administration is may be used for the cyanide poisoning, because it forms cyanocobalamin. For in the pernicious anemia, vitamin B12 should be given intramuscular injection 100 to 1000 microgram of the cyanocobalamin for the 5 days, followed by 100 to 1000 microgram each month till the correct blood pictures there. This is the relationship how vitamin B12 and folic acid are related to each other. This vitamin B12, they get absorbed with the transcobalamin 2 complex, and when this vitamin B12 get reach into the cells, this vitamin B12 is very important for the conversion of homocysteine to methionine, and also for activation of this folic acid, and this folic acid and this play a very important role along with this vitamin B12 in the purine synthesis. That the purine is the basic component of the DNA, and here vitamin B12 is responsible for the formation of the succinyl coenzyme A and also glutamic acid. Now the metabolic function. Vitamin B12 is intractally linked with the folate metabolism, as we have discussed earlier, in many ways, and megaloblastic anemia occur due to the deficiency of either the folic acid or the vitamin B12, and that is the indistinguishable. And the active form of the vitamin B12 generated in the body of the deoxyribonucleic and methylcobalamin. This is the functioning of the vitamin B12 is essential for the conversion of homocysteine to methionine. First, it is the methyl tetrahydrofolic acid get converted to tetrahydrofolic acid, and this methyl group may combine with the vitamin B12 to form methyl vitamin B12, and this methyl vitamin B12, when converted to the vitamin B12, it transfer one methyl group to homocysteine to form methionine, because homocystinemia is a very common problem for the atherosclerosis and other disease. And purine and pyrimidine synthesis is affected primarily due to the defective one carbon transfer because of the folate trap, because the deficiency of the folate. And the most important of these is the inability of the thymidylate for the DNA production. Other functioning is the conversion of manolic acid to succinic acid, and conversion of methionine to acetoinosine methionine. And vitamin B12 is essential for the cell growth and cell multiplication, because it is very important, play a very important role in the DNA synthesis. Now comes up the distribution, how the vitamin B12 comes from the diet get normally distributed. Vitamin B12 make a complex with the transcobalamin here. Vitamin B12 present in the diet, it make a complex with the intrinsic factor that gets secreted by the GIT. And this vitamin B12 and intrinsic factor when get it absorbed, and once it get absorbed, release into the you see the systemic circulation, it make a complex with the transcobalamin 2. And this transcobalamin 2 is a very important proteins that is present in the plasma, and it very important for the transportation of the vitamin B12. Other form of the transcobalamin is the TC1 and TC3, but most importantly is the transcobalamin 2. During the if even the plasma level of the vitamin B12 is sufficient and the transcobalamin 2 is plasma concentration is poor, person may get develop pernicious anemia. This transcobalamin 2 is also very important, and this complex transcobalamin 2 vitamin 2 get when it enter the systemic circulation, it get in accumulated in the liver, where it get stored, or when it get enter the peripheral tissue, where it get converted into the methyl vitamin B12 or deoxyribonucleic vitamin B12. Elimination. When we see the transcobalamin is very important for its circulation, and in the subject where the congenital absence of the transcobalamin to megaloblastic anemia occurs despite for the relatively normal plasma concentration of the vitamin B12, and that can be treated by the vitamin B12. And deficiency of the intramuscular absorption of the vitamin B12 have been reported in children with the methylcobalamin aciduria and homocystinuria. That is the common problem. And this is the drug interaction. And these are the alcohol which interfere the absorption of the vitamin B12, para-aminosalicylic acid, colchicine, neomycin, cholecystamine, anticonvulsant drug, very important, and metformin. These are the drugs which interfere the drug absorption of the vitamin B12 through by the GIT. H2 blockers, proton pump inhibitor and antacid also decreases its absorption. Now comes on the treatment. In the uncomplicated pernicious anemia, in which the abnormality is restricted to mild or moderate anemia without leukopenia, thrombocytopenia, or neurological signs or symptoms, and the vitamin B12 is sufficient to treat this type of the uncomplicated pernicious anemia. And the megaloblastic erythropoiesis, when the confirmed the megaloblastic erythropoiesis is there, the patient should receive intramuscular injection of 100 mg of the cyanocobalamin, that is the synthetic form of the vitamin B12, and with 1 to 5 mg of the folic acid according to condition for the next 1 to 2 weeks. And patient should relieve daily and intramuscular injection of the 100 mg of the cyanocobalamin may be injected with the supplement of the folic acid. If other cardiovascular condition is there, you can give the drug accordingly. This is the long-term therapy. Once began vitamin B12 therapy is started, it must be continued throughout the life, when the according to the situation of the by monitoring the hemostatic system level of the RBC. Intramuscular injection of the 100 mg cyanocobalamin every 4 weeks is sufficient, and patient with the severe neurological symptoms may be treated with a larger dose of the vitamin B12 when prepared immediately after the diagnosis. And other use of the vitamin B12 in the trigeminal neuralgia, multiple sclerosis, neuropathic pains, various psychiatric disorder, poor growth in nutrition, and the person will get is feeling tiredness. And the children with the methylcobalamin aciduria, it is the very common problem that is treated by the vitamin B12. Now comes some the folic acid. These are the normal foods source of the vitamin B, folic acid. Also liver. It is a water soluble conjugate of the pyridine, para-aminobenzoic acid, glutamic acid, and the toroidal ring. And most of the folate get absorbed in the diet, converted to the active form of the tetrahydrofolic acid. And the major storage form of the folic acid in the liver is N-methyl tetrahydrofolate. And these are the principal source. Calf liver again contain richest source. Wheat germ is also richest source. And the soybeans per eggs, one egg contain 100 microgram. Spinach and broccoli, these are spinach and broccoli are the good source for the vegetarian. The chemical structure, it is the glutamic acid, para-aminobenzoic acid, and pyridine. This is a complex of this is a glutamic acid, para-aminobenzoic acid, and pyridine. And normal function, production of the RBC, production of the WBC, protein metabolism, production of the nucleotide, and proper formation of the development of the central nervous system. Major symptoms of the folic acid deficiency, that the most pronounced effect of the folate deficiency in the cellular proliferation, and because it inhibits the DNA synthesis get inhibited, impairment the whole white blood cells development of the leukopenia, reduce the immune response to the infection or the cancer, and impaired cell growth in the digestive tract, inflammation of the tissue in the mouth, stomach, and intention to reduce absorption of the intestine to reduce the absorption of this nutrient. Impaired fetal growth also developed, birth defect, and the particular neuronal tooth defect, that is the spina bifida, get commonly observed. Use of the folic acid as a prophylaxis for the birth defect, atherosclerosis, enhance the immunity, cancer, psoriatic or the nervous disorder. These are the drugs which interfere the absorption of the folic acid, dietary folic, that is aspirin, oral contraceptive pills, antacid, anticonvulsant, and antibiotics. And these are the antagonists, that the methotrexate, physiological antagonists. Folate present in the food are largely in the form of the reduced form, that the reduced polyglutamate. And this upper part of the GIT, especially duodenum and upper part of the jejunum, is responsible for the absorption of this folic acid. And before the absorption of the folic acid that is present into the GI, present in the diet, it must be hydrolysis by the enzyme petroyl glutamyl carboxypeptidase and get further reduced, and methylation occur on the enzyme that present on the mucosa, the dihydrofolate reductase. And when this folic acid that present in the diet, when get hydrolyzed, reduction, and followed by the methylation by the enzyme dihydroxyfolate reductase, it able to absorb And when it's come to the systemic circulation, with the plasma protein binding, it enter into the liver for its reservoir or enter into the peripheral tissues for the normal function. These are the normal function of the folic acid. Folic acid is inactive as such and reduces to the coenzyme. When folic acid, it get converted to dihydrofolic acid by the folate reductase, and this dihydrofolic acid get further converted into tetrahydrofolic acid by dihydrofolate reductase, and this tetrahydrofolic acid is active form. And this tetrahydrofolic acid mediated a number of the one carbon transfer reaction carrying the methyl group and as an adduct. The conversion of the homocysteine to methionine, because when one methyl group add into the homocysteine, it converted into the methionine, and vitamin B12 act as a intermediary carrier for the methyl group. This is the most important reaction for the release of the tetrahydrofolic acid from the methylated form. Here you see generation of the thymidylate, that is a basic constituent for the DNA synthesis. Deoxyuridylate get converted into thymidylate, and when this this dihydrofolic acid converted into tetrahydrofolic acid by dihydrofolate reductase, and when the tetrahydrofolic acid converted serine get converted to glycine, tetrahydrofolic acid transfer one methyl group, add one methyl group by the serine, and it produces methyl tetrahydrofolic acid, and this methyl tetrahydrofolic acid is able to transfer one methyl group and produces the thymidylate, and this is the basic constituent for the synthesis of the DNA. And during the deficiency of the this folic acid, the production of this thymidylate or the other de novo protein synthesis gets significantly hampered. Now comes on the erythropoietin. Four things. This is the endogenous glycoprotein hormones, and secreted by the peritubular capillaries in the cortical region of the kidney. Near about 80% that gets secreted by the kidney and 20% by the liver. And hypoxia is the basic stimulator of the synthesis of the erythropoietin. And when the chronic deficiency of the erythropoietin is there, it may lead to the DNA cleavage followed by the apoptosis of the erythroid stem cells of the bone marrow. And erythropoietin has a significant positive impact for the patient of the chronic renal failure, and this erythropoietin consistently improves the hematocrit and hemoglobin level. An increase in the reticulocyte observed into the 10 days, and this hematocrit and hemoglobin level near about 2 to 4 weeks, and the most patient can maintain the hemocritic level about 30% with the erythropoietin dose of 50 to 150 international unit per kg intravenously. Failure to the respond to the erythropoietin must be commonly due to the concurrent iron deficiency. So during the erythropoietin therapy, iron supplement may be ensured and folate supplement may be given. Toxicity. Most common toxicity of the erythropoietin is associated with the increased hemocritic and hemoglobin, induced hypertension and thrombotic complications that is induced by the hemocritic and hemoglobin. And these difficulties can be minimized by raising the hemocritic and hemoglobin slowly and by adequate monitoring of the level of this hemocritic and hemoglobin, and subsequently with the hypertension. And some cases allergic reaction has also been observed. Now the use of the erythropoietin. The primary indication of the erythropoietin is the anemia, particularly in the chronic renal failure, which is due to the low level of the erythropoietin. Only symptomatic patient with hemoglobin level less than 8 gram per dl should be considered for the erythropoietin therapy. It is prudent to start with the very low dose of erythropoietin and keep the hemocritic level between 30 to 36% and hemoglobin level 10 to 11 gram per liter. Monitoring of the adverse effect. Recombinant erythropoietin therapy is the conjugation with adequate iron intake can be highly effective in a number of the anemias, especially those associated with the poor erythropoietic response. Patients with anemia secondary to the chronic kidney disease are ideal candidates for the erythropoietin alpha therapy. And this erythropoietin alpha therapy 150 units per kg 3 times a week or 450 to 600 units according to the situation per kg once a week can reduce the transfusion requirement in the cancer patient undergoing the chemotherapy. Or this erythropoietin alpha 600 unit per kg can be given on day before 21, 14 and 7 day before the surgery with additional dose of 1 dose on the day of the surgery. Thank you. If you have any problem, any doubt, you can write a mail, that is the hnyadav@gmail.com. If you have any problem, please don't hesitate to give a mail, that is the hnyadav@gmail.com. Thank you.